Hello, my name's Jim White, and I'm a professor of medicine, pharmacology, and physiology at the University of Rochester in Rochester, New York. I founded and still direct the Pulmonary Hypertension Association accredited CCC in pulmonary hypertension, and I'm here today to talk a little bit about Freedom EV, the culmination of a 15-year development program for the use of oral treprostinil in patients with pulmonary arterial hypertension. The Freedom EV trial launched in 2013 as the fourth global study looking at pulmonary hypertension patients started on oral treprostinil in what we call an event-driven design. That is to say, patients were enrolled and followed on either treatment or placebo for years until the number of events was reached, and then the study was closed and analyzed. The study began at a time when initial combination therapy was not yet in vogue, and we were still starting patients on monotherapy. Our goal to establish the study was to enroll patients very quickly after they started monotherapy, an early combination therapy, if you will, strategy. As such, we enrolled the patients we desired to enroll, largely functional class 2 patients with an average walking distance of about 400 meters, the longest of any of the walks at entry in the global studies to date. We took this homogeneous population, mostly treated with background PDE5 inhibitors, and showed that we could reduce the risk of a clinical worsening event by 26% over the course of the study. We were surprised to find out after the study closure that our plan to study risk improvement actually showed that the oral treprostinil patients were much more likely to die, statistically significantly more likely to die in the first year, as assessed by the non-invasive French risk score. And so once we adjusted for that baseline imbalance in risk, we actually had a 39% reduction in clinical worsening events. Of course, this drug is a prostacyclin, and so treprostinil has side effects that are typical for the drugs that you're used to using in parenteral form, Remodulin and Velletri. And so oral treprostinil is no different, and nausea, headache, diarrhea, flushing were common. And in fact, about 18% of patients dropped out because of intolerable adverse events. In summary, Freedom EV represents an exciting step forward in the use of oral treprostinil. During the conduct of EV, what became most exciting was that follow-up risk assessment was critical in determining outcomes. Yes, baseline risk is obviously important, but follow-up mattered even more. And so we decided, as part of our statistical analysis package, before unblinding, we decided to assess risk and to determine whether oral treprostinil assigned patients not only benefited in terms of clinical worsening, but also benefited in terms of risk as assessed by the French non-invasive score. So we were incredibly pleased to see that as early as week 12 and clearly at week 24, 36, and 60, we saw very sharp improvements in the risk profile for oral treprostinil treated patients. We started out with relatively high NT-proBNP measurements in the thousands as a median average. And as you'll see in the graph that's part of that paper, a striking difference in the oral treprostinil treated patients over time, where NT-proBNP marches down at week 12, marches down at week 24, marches further down at week 36, and the placebo patients sort of stay the same or creep up. Even though a majority of the patients started in functional class 2, we were able to show that patients shifted functional class favorably with oral treprostinil as compared to placebo. And that meant both there was improvement in the tree-assigned patients as well as decline in the placebo patients. So both were true. We saw patients improve with oral tree and decline in unblinded placebo. The final component of the risk assessment is 6-minute walk. And at week 24, there were numeric improvements in 6-minute walk in the oral treprostinil group. But the placebo patients, remember, who started out with an average walk distance of 400 meters, they also stayed about the same or improved by a few meters. So we did not have a statistically significant difference at week 24. Not surprisingly, the placebo patients had started to fall off by week 36, and then the statistically significant difference was readily apparent. The oral treprostinil patients had gains at week 12, even further gains at week 24, maintained those gains at week 36, but the placebo patients had finally fallen off. And so at week 36, week 48, and week 60, the difference in 6-minute walk is statistically significant. At study closure, when we say the study is completely over in October of 2018, and we unblinded the study, and we knew about deaths from people who had left the study, and we accounted for those. We said, okay, overall, how many placebo-assigned patients do we know about who died? And the answer was 60, 17%, as compared with 38 who were initially assigned oral tree, 11%. And that, without any adjustment, was statistically significant, a 37% relative risk reduction in death, p 0.03, along with the clear reduction in clinical worsening events, along with the clear improvement in risk profile, along with the clear reduction in symptoms as measured by functional class, and the clear reduction in NT-proBNP, and the improvement in hemodynamics. I feel confident that this mortality benefit is likely grounded in truth, even though we have the missing data, and we have to acknowledge that.
Orenitram, treprostinil, extended release tablets. Indication: Orenitram is a prostacyclin mimetic indicated for treatment of pulmonary arterial hypertension, PAH, WHO Group 1, to delay disease progression and to improve exercise capacity. The studies that established effectiveness included predominantly patients with WHO functional class 2 through 3 symptoms and etiologies of idiopathic or heritable PAH, 66%, or PAH associated with connective tissue disease, 26%. Important safety information for Orenitram. Contraindications. Avoid use of Orenitram in patients with severe hepatic impairment, child Pugh Class C, due to increases in systemic exposure. Warnings and precautions. Abrupt discontinuation or sudden large reductions in dosage of Orenitram may result in worsening of PAH symptoms. The Orenitram tablet shell does not dissolve. In patients with diverticulosis, Orenitram tablets can lodge in a diverticulum. Adverse reactions. In the 12-week placebo-controlled monotherapy study and an event-driven placebo-controlled combination therapy study, adverse reactions that occurred at rates at least 5% higher on Orenitram than on placebo included headache, diarrhea, nausea, vomiting, flushing, pain in jaw, pain in extremity, hypokalemia, abdominal discomfort, and upper abdominal pain. Drug interactions. Co-administration of Orenitram and the CYP2C8 enzyme inhibitor gemfibrozil increases exposure to treprostinil. Therefore, Orenitram dosage reduction may be necessary in these patients. Specific populations. Animal reproductive studies with Orenitram have shown an adverse effect on the fetus. There are no adequate and well-controlled studies with Orenitram in pregnant women. It is not known whether treprostinil is excreted in human milk, or if it affects the breastfed infant or milk production. Safety and effectiveness of Orenitram in pediatric patients have not been established. Use of Orenitram in patients aged 65 years and over demonstrated slightly higher absolute and relative adverse event rates compared to younger patients. Caution should be used when selecting a dose for geriatric patients. There is a marked increase in the systemic exposure to treprostinil in hepatically impaired patients. Please see full prescribing information and patient information at www.orenitram.com or call 1-877-UNITHER, 1-877-864-8437.